Thanks for being here. I'm Lee Muser, and I'm here representing Monroe County Cares. Monroe County Cares is a state designated local coordinating council, and our job as a local coordinating council is to distribute countermeasure fees back into the community through treatment programs, justice programs, and prevention programs. So that's just a little bit about CARES. We try to facilitate 2 community meetings a year. So this is our fall community meeting. And I'm really excited to have 3 folks here to talk about MATs and medically assisted treatment. So I will just hand it over to the 3 of you. Our first question will start, Ashley, if you're fine starting. Please share your name and experience with MATs, and you can give like work or personal information, and that question will be for all of you. So when we go through all of you with one question, then we'll go to the next question. Yeah. And so we'll do, just for if there's people in the audience watching, we will do questions from here or from Teams at the end. Yeah, great. Thanks.
Thanks, Lisa. My name's Ashley Collins. I work at Centerstone. And in terms of my experience, I've worked at Centerstone for almost 8 years with people that are on medicated assisted treatment. But prior to that, I worked at the Department of Child Services for 5.5 years. A lot of people were also on medicated assisted treatment. And I have family members and friends that have either been on medicated assisted treatment or are still on medicated assisted treatment.
Hi, thank you for having me. My name is Autumn Allor. I'm the Treatment Center Director for MedMark Treatment Center here in Bloomington, Indiana. I've worked with vulnerable populations for over 20 years now, starting out in mental health and dual diagnosis. I also have family members who have suffered from addiction, and we currently have 370 patients that we serve here in Monroe and surrounding counties at MedMark.
Okay, we're going to try this. I got a bad voice today, folks. My name is Nick Voiles, and I have been on medicated assisted treatment on and off since I was 18. I was on once for a stretch of 18 years. It's an absolute life changer. Methadone. I don't know about buprenorphine, but methadone is an absolute life changer. It is the #1 gold standard for people with opioid use issues. I have seen it time and again save my life 1,000 times and everybody else's lives. And that's my relationship with it. And I also work at the Indiana Recovery Alliance, where we help people get on it and help people with a whole bunch of stuff surrounding those issues.
All right, thanks to the 3 of you for being here again. All right, our next question. Can you discuss some of the most common medications people are prescribed for MAT? And I'll let you go in the order you want to go in. If you want to change up the order, that's fine. If you want to stick with the same order, that's fine. All right, I'll just say the question again. Can you discuss some of the most common medications people are prescribed for MAT?
So when we're talking about substance use disorder medicated assisted treatment, as Nick pointed out, the gold standard is methadone. There's also Suboxone, and there's a whole bunch of different things that are in kind of the buprenorphine bucket, including Subutex, Sublocade, Subzolve, and now a newer thing that came out is Rexulti. And then there's Vivitrol and Naltrexone, and both of those medications can be used for opiate use disorder and alcohol use disorder. And then there's also Antabuse and Campril for alcohol use disorder as well.
Ashley covered all of the medications that are listed, but it's not a one-size-fits-all treatment. One person might be successful on one type of medication and another person might not. And so each one of these is just like for ourselves, the way we metabolize, access to treatment may vary. So I wanted to add that as well.
They've said all the ones for opioid use over. I am going to say this. There's a glaring missing piece, which is something for methamphetamines and some other drugs, especially methamphetamines. There are people who are pioneering this, and it works. We just need to really put some thought and effort into this, seeing that we're now in this endemic. We're not in an opioid epidemic anymore, and that when you're talking about something like methamphetamine that costs $10 or $20 for a gram, you need to be thinking about what we can do to stop that. You know what I mean? And we need to very much so look into assisted treatment and put the power in people like her's hands to be able to have that treatment to offer other people.
Thank you. The next question is, what qualifies someone for taking MAT? So what qualifies? Can just anyone take it? Like what's the discernment process? Yeah, thank you.
Typically, like the medications we just went over are for opiate use disorder or alcohol use disorder. They're also, especially depending on the medication, there's like you need to be medically cleared for them. For instance, Vivitrol can be really hard on your liver, and if you have like hepatitis or something, the doctor needs to like look at those levels to determine if that's appropriate. And I'll let Autumn kind of talk about the methadone piece of that because they have a medical screening process as well. And then also drug screening people. And I say that I think historically we've looked at drug screens as punishment. They're used to then invoke some kind of consequence. But the truth is right now, people don't know what they're taking. And so a lot of times that drug screen tells us what's in their system. We've had people come to our residential facilities saying, I'm only taking benzodiazepine, and when we drug test them, the only thing in their system is fentanyl. And so this is becoming more and more important to for them to actually know what is in their system, because what their dealer is saying they're putting into their body may not be the case, or maybe it's that plus 4 other things in there. So.
When we get calls through our call center, when we're evaluating patients, they may be in active withdrawal or in active addiction or have relapsed. We have walk-ins, we do intakes 3 to 4 days a week. And so the person would have to have the mental capacity to be able to function independently and to be able to make those decisions. I think that's important to express. Oftentimes, loved ones want to support someone entering into treatment, but it is that individual's decision. And so they need to be able to walk themselves through the program. A family member couldn't come in and fill out all the paperwork for them and answer all the questions and escort them to the front desk and to the dosing window. It needs to be that person is seeking treatment for themselves.
I'm going to answer this question carefully. First of all, what Ashley said is correct, although I'm going to say something about that. Drug testing can be important if if a patient initiates it on their own. That's something that's really important. The way that it's set up now, it is punitive, and it's the treatment decider for whether you're passing or failing. So there's so many other things that go on in a person's life that if they're just relying on the content of chemicals in their body as their treatment indicator, it is failing time and time again. I'm saying this. Also, I just want to make this clarification really clear. This has nothing to do with Autumn. What she's done at our current clinic and within the system is nothing short of a miracle. The clinic system itself is broken. People come in there, they're sick, they're just desperate, and people make them fill out all this complex information because that's the law. They have to do this. They don't have a choice. So you go through all this, signing all this stuff away, thinking, okay, whatever, just give me this dose. And it's usually not enough with fentanyl to even come near it because they cap it at 30 milligrams, usually 40, sometimes a little bit more. And like I said, I'm just being really clear. This is not a thing on the MedMart clinic. This is clinics, the system. And the idea that when you say what should be, what's the thing that there should be for medicated assisted treatment, it should be nothing but needing the medicine. The miracle's in the molecule, right? Time and again, we see that there are all these bit layers people put on counseling, this, that. There should be a choice. If people want those, And there's a lot of people that actually want those. In my advocacy, I have really came across a lot of people who want the clinic system. They want that structure. I used to say nobody wants it. I can't say that anymore. There just needs to be options for people who do not need that and just need a doctor who can prescribe them medicine and they can go to the pharmacy and pick it up. Suboxone is kind of like that loosely. And we're working on it nationally to get methadone freed from the chains that it's in. But right now, it is horrible. It is an absolute scare to try to deal with the clinic systems as they are now. You know, we got lucky here that we have the staff that we have at MedMark that like works tirelessly to do things I've never seen in any other clinic as far as taking care of patients. That's why I'm at that clinic. It's like something that I just have never seen before. So I do agree with you. I think people should have the ability to look at their stuff. I think we need to, I'll stop right after this. I think instead of that, we should robustly invest in FTIR machines that can test the drugs pre-taking them so they don't have to ingest them to find out what they are. It's odd that drug use, most of our interventions happen if you die or if it's something illegal. So like we just need to loosen these chains to be able to allow people to have this stuff done. It doesn't have to be done by Paul or Susie. It can be done by a medical professional. It can be done by a person in a research facility. So, but everyone should have open access to that.
And before we go to the next question, there was one other thing that I thought about is sometimes, and this doesn't necessarily need to be a drug screen, but anytime you're taking like Vivitrol or naltrexone, you have to have opioids out of your system for at least 7
Thank
days.
you. That's really good.
And so, I mean, you could get really, really sick. And I always educate people about that and like, look, like I'm not here to get you in trouble. Just know you're gonna go into precipitated withdrawal if you're on that, you take this medicine and you've been on opioids in the last 7 days. And I think that's sometimes the challenge with Vivitrol and naltrexone is if somebody's in active use, if they could stop for 7 days, they wouldn't need the medication. And so I think there's times where that's really appropriate, and a lot of times it can be when people are like conditionally sober or have had to like stop using, whether it's they're incarcerated or they've been hospitalized and that sort of thing, and use that as a try. But somebody that's actively using fentanyl daily can't stop for 7 days. They need something else. And so kind of like what Autumn was saying, it's not a one size fits all. It's figuring out where you are and knowing all your options and then making a decision based on that.
Yeah, thanks for that clarification. And what you're really both talking about, or all of you are talking about, in some level or another, is barriers, right? There's a lot of barriers. Some you've already named, and you might repeat them with this next question, which is, what barriers have you noticed with yourself or your clients that prevent them from getting or staying on MAT? So if you did name them already, you can name them again, just so that the audience, so that the viewers really understand that there are a lot of barriers that people are dealing with.
And I would say number one is shame that's associated with the stigma of medicated assisted treatment. And that is not just people that don't use substances, that's even within the recovery community that it exists. And that is huge. And when I'm training people at Centerstone of having these conversations, like if you don't like MAT, don't make that your client's problem. It's not their problem. That's something you need to work through because everyone's recovery journey looks different. There's, again, not a one size fits all. And, you know, there's a lot of things that people say that's like, you're not in true recovery, this is a crutch, you're just trading one substance for another. And all of those things are not true. And I've seen people with my own eyes that I've been working with for years who couldn't achieve recovery without medicated assisted treatment. And then they don't want to go to some recovery meetings because they're going to be given a lot of crap about their choice of recovery path. And it's not right. And I know this sounds kind of dramatic, but these are the times that we're living in. Shaming somebody because of their medicated assisted treatment can kill them. If they stop using it, they're at really high risk of returning to use. They're at very high risk for overdose. And we just need to come at this from a place of love. We're all humans. We all have struggles. one person's struggles are like may look different, but like we're not supposed to be comparing those things. Like their journey is their journey, their struggles are their struggles. Love them where they're at. We take this approach of punishing and just looking at them and like they're less than if they're having a certain struggle. The truth is I would say most people in this country have an addiction to something. I'd say most people have an addiction to carbohydrates. I know I'm in that category, but you know, my addiction to carbohydrates doesn't put me incarcerated, you know? And so, we really just need to completely shift the way that we're looking at things and love somebody where they are. Some other barriers are transportation, especially if they're going to a methadone clinic. You have to go there every single day. And there may not be a clinic close to you. Some people have to drive an hour and a half each way to get that medication. And when you're saying that, like, I don't think a lot of people understand, like, every single day, no matter if it's the weekend, a holiday, there's a snowstorm, your kid is sick, you are sick. If you don't go, you don't get your medication. And this is a medication that helps people be able to function.
Can you explain to folks who don't know this why people have to go every day? Why they can't just, like, you know, if I'm on a prescription, I don't have to go to the pharmacy every day or to my doctor every day. I have a 30-day supply. So can you talk us through that?
Yeah, absolutely.
You're
So,
the expert.
you know, when we're looking at medication-assisted treatment, there are a lot of medications that you have to wean yourself off of or taper off of. I can't go without my thyroid medication for very long that my body doesn't react. With medication-assisted treatment, it is designed to stabilize that individual so that they can reach a point that they are not as reliant and eventually not at all reliant on substances like fentanyl. It's long acting, the cravings go away, they're not experiencing a high off the medication, but it is a medication that once it's absorbed into the system, it's one that you have to wean yourself off of, just like you would. There are some psychotropic medications. There's medications that are used for anxiety and depression that you can't just go without or your body reacts. Because of addiction to other substances or prescribed opiates or overprescribed opiates, the reaction is so much more severe. Okay, so that person is going to get very, very sick very, very quickly, as to whether, as with some of the other medications I mentioned, you may go longer without seeing the side effects of going without your medication. It's going to be a more severe reaction.
You asked the question, you asked it again. I'm sorry. I just want to hear what you said.
Well, I asked why people can't go home with like a 30-day supply of a medically assisted treatment, like for example, or for a longer, why they have to go back every day.
Yes, I'm sorry, I misunderstood
That's
your
okay.
No, that's okay.
I
No,
misunderstood
what you
your question.
Spoke to was great also, so thank you.
In the state of Indiana, you have to have what's called earned take-home medication in my realm. So methadone, you have to be in the treatment program for 90 days. You have to have 1 hour. This is for introductory. So if you're coming in as a new patient, I'm describing our program, you have to be in the program for 90 days. Your screens have to meet the requirement, which would be to only have methadone and methadone metabolites in your system, and you have to be in compliance with your counseling. So 1 hour of counseling per week, whether that be in person or group-based counseling, in order to receive your first initial bottle of take-home medication for you to self-administer. So in the state of Indiana, you have to work towards that, and it's a long process of 90 days, you know, and building towards that. And in that instance, you would still if you've been in complete compliance and you're in that phase of treatment, you'd still only get 14 days is the maximum amount.
And correct me if I'm wrong, I think federal law allows you to take a 30-day supply. Indiana state laws say only 14 days. So there's a lot of times where federal law says something, but then states put even more restriction on those things.
And revisiting the question in regards to barriers, transportation is one. There is a service that individuals that receive assistance can utilize. However, oftentimes there's not enough drivers to meet the demand, and a patient might get dropped off in the morning and they don't get picked up for 3 or 4 hours, or they don't get picked up at all. I've also seen patients that have ridden bicycles miles to get to us, or walked. They'll start very early in the morning and walk however many hours to get there. And those are things when people are, have stigma, those are the things that they don't see. A lot of people have never witnessed pulling back the curtain and the reality. And I can stand in front of you and speak intelligently in my business attire, but I will not hesitate to get down on the floor on my hands and knees with a patient that's vomiting to get them through the intake, to give them hope. And there's a whole world out there that exists where people are suffering and they've never received parenting. Well, they should just know better, or they're adults. This is a generational thing that's happening, and they haven't received people think of the family structure in a Norman Rockwell painting, and that's not what these individuals have experienced. They've experienced a significant amount of trauma without proper medical care, without proper intervention. And so, they're trying to rebuild their lives from scratch.
Wow. The clinic system is a clinic of culture of cruelty. It was created and based on a probation model to punish people. Systematically, they've done a really good job at that. What I mean is, the way the system was originally created was to make people have to work to get these things that they deserved from the beginning. In the 70s, they had given people stuff like whole months to take home. They only did that because of there was only a few clinics here and there, When I first started going to the clinic, sorry, my voice is kind of messed up. When I first started going to the clinic, you could get a month's worth of take-homes, but you worked so hard, right? The only treatment indicator is an illicit or non-illicit test. That means if there's stuff in your system, you don't deserve take-homes. So if I build an organization, have 3 kids, build a house, create a wonderful space in my community, that means nothing compared to what substances in my body, even weed. We are looking at a place where this is being changed nationally. During COVID, they had these things called COVID exceptions, where until, this is before she wasn't there during this, so there was the Limestone, the people that owned it, weren't even taking new patients. They would make you sit all day in there when there's a pandemic going on where people can't, we're trying to keep distances. So we begged, and SAMHSA to change the laws for the first time in the entire time I've been a methadone patient. They changed them for the better. For a minute, they took these things called the COVID exceptions, which means that anybody, regardless of illicit or licit test, can receive up to whatever your state will allow take-homes. Things changed. It's now being recorded in real time, and watching all of this amazing, magical thing going, that all these thoughts that these bad things were going to happen don't happen. They just don't happen. There's bills in Congress signed by 67 bipartisan people to pass this bill to free it from the chains of cruelty that it sits in. It is the only tertiary healthcare system in our whole system. It stands alone. The only place you can go to for help to change any of the laws is the SOTA, who's often, like her, given so much to do and so many rules that it's hard to break it out there. I watch her time and time again do things that are just amazing. I mean, I don't know how to say this enough. I've said this about her enough times, and I don't think you understand what it's like to be in a system like this and to be persecuted. I lost all of my take homes 14 days after I'd been in a clinic for years because a lid was different. And even though I brought the soda in and the state was sticking up for me, they still took them. Still made me go back to daily driving to Indy every day. This is very common at the clinics. Very common. Most patients are, like me, scared of reprisal. The only reason I'm standing and saying these things is because she works there. In all honesty, I've tried to mute this other places. I don't feel she would ever do that to me, so I don't mind saying this. And she's working her ass off to make it be better. But it is a culture of cruelty. The system is broken and painful and causes harm more than I can ever imagine to tell you. If all of you guys were to go to the clinic and have to do what we had to put up with, you'd be in the streets. You'd be in the streets. They don't pay them enough. They don't give them enough stuff for what they do. They work too many hours. They put their heart and soul into things that are just thrown against them at every turn, the same as we do. And it doesn't matter because people really don't care. And so I urge you to try to care because there's enough of us now that it's open and it will change. It'll change. You can't shut the door anymore. And so when you ask me things about this, it's really hard for me to talk about this sometimes because it's so emotional for me because it's personal. But people die. People die from getting to deal with the clinic systems. There are whole groups that won't walk into that clinic because they believe that it's like it's better off to be stuck on a street drug than to get on a government-controlled drug, which is kind of crazy because, if it was free, these people would have life-saving changes, So I just want to make sure that I don't know how to reiterate this enough, but the system is broken, causes immense pain and damage, and doesn't need to do that. So
I had a couple other barriers.
Yeah, go ahead. Yeah.
So one is health insurance. They don't have health insurance. Or I have a lot of clients I work with currently who, now that we're not in a state of emergency and they're looking at their income now, don't qualify for Medicaid. They make too much, but they don't make enough to get the private insurance with their work, or they don't make enough to make marketplace insurance payments. And that is a huge barrier. I was just at MedMark this week, and that was something that came up in our discussion is like, what do we do about this? And I mean, that's straight across for like not just medicated assisted treatment, healthcare in general, they're not able to access because they can't afford it. But the government says they make too much money. Another huge thing, especially when we're talking about methadone, is access to all levels of treatment. In the state of Indiana, I just got done with a 4-year SAMHSA grant that started in September of 2020, and I was appalled when I found out that residential care in the state of Indiana, people that are on methadone do not have direct access to that. They don't. They're told, sometimes you'll hear of treatment places like, oh yeah, we did accept this person, but a lot of times they give them some arbitrary milligram level that they have to get down to, or they tell them they have to straight up stop taking a medication that is helping them function in life. If we did that to somebody that had blood pressure issues and said, you know what, you're just going to need to try a little bit harder to control your blood pressure. Like, that's laughable, right? This is the same sort of thing, but because people put moral judgments on people that have substance use disorders, they cannot access treatment. And in the state of Indiana right now, besides Pinnacle in Martinsville that has their own OTP on site, Centerstone is the only place, and we only have 3 in the entire state of Indiana, 2 male facilities and 1 female facility. Centerstone does not prescribe methadone. We work with MedMark, we work with other OTPs throughout the state to create OTP is opioid treatment program. We don't call them methadone clinics anymore because when you say the word methadone, people block you out. So we had to rename them. So we work with OTPs all over the place. People from the very northern part of the state, 4 hours, 3.5 hour drives are coming down here to Centerstone to get treatment, residential treatment for the first time ever. That is not okay. We need to do better. And the issue with it is it takes more work. But the truth is anything that's worth like worth doing, anything that's the right thing to do generally does take a lot more work. And we need to be working together and figuring that out. Because at this point, besides Pinnacle and Centerstone, they don't have any other options, and they should be able to access treatment at every single place, regardless of being on methadone or not. And I'd say another barrier with MAT is recovery housing. There's not a lot of recovery houses that accept MAT, or they'll accept other forms but not methadone. And first of all, we don't have enough recovery housing in the state of Indiana. We keep opening up residential facilities. We don't need any more of those. We need recovery housing at all levels of care. Level 3, in our level 3, where, that's a great step down from residential. I do think people give Oxford a really bad name. It is what it is. It's a level 1. When you come out of residential straight to a level 1, you're not ready for that. They end up using, and then they're like, oh, Oxford. Well, it's not even like peer run. They have like group meetings and stuff, and there's a place for that in the continuum. But because there's not enough recovery housing at level 3 and level 2 that really help wrap around them from the residential, help them with their management, help them with their healthcare stuff, they just put them there, and they have to like learn how to adult all on their own. And I would say somebody that has maybe had like a lot of recovery under their belt, return to use, goes back to residential, they might be able to do really well. But most people that are going into residential treatment that have been an active addiction for years cannot go from residential to a level 1 without them backsliding or something happening. And so that's a huge barrier. If somebody needs to take medication to feel normal, they can't access recovery housing. And we all know what happens when people go from residential back into the exact same environment they came out of. The environment didn't change while they were in treatment. They totally regress and go back to all of those same behaviors. And that's a huge, huge barrier. And we need to do better about residential. We need to do better about recovery housing.
So I'll say, just FYI, all the things she just stated wouldn't be a problem if the clinic system wasn't what it is. Every single thing she just said would not be a problem if we changed the clinic system. None of it. The problem is we have this one thing siloed into this small little box, right? And until we free that, then these wouldn't be problems. It'd just be like any medication. Do you see what I'm saying? But because it's locked in these confines and this like myriadic thing from it can be the federal, and then it can be the state can make it more punitive, and then the clinics can make it even more punitive. Most clinics are owned by venture capital, excuse me, I'm not going to say it the other way, are owned by profiteer companies, right? They're not owned by people who give a shit. You're a commodity to them. You're a number, a dollar. You know what I mean? And the idea is that these systems need to at least be changed and taken apart and restructured to do things like she's talking about. You know what I mean? Like, but until we get rid of the clinic system, this will never be anything. We'll sit in the same spot we sit in all the time, wanting all these things and never getting them, because we have to concentrate on the problem where the problem is. The problem is the clinic system. There should be a choice. I'm not saying we should get rid of the clinic systems, but like until we start talking about that and focusing on that, all the barriers are negligible, because that's the problem with the barriers. Do you see what I'm saying? And we need to make sure that we're focusing on that. And you're right, we need to get together. And that's the thing, is like there's too much of this banter between recovery, harm reduction, MAT, blah. It's all garbage. You know what I mean? We're all in the same boat, but they've got us fighting each other. You know, and it's what they do, and it's intentional. The second we step out of that, we are one of the largest blocks of people in the world. If you think about it, there are so many people in recovery, using drugs, have felonies, have dealt with some place in the carceral system. They're beautiful, wonderful people. They just need to be freed from the chains that hold them. And one of the biggest chains that holds them is the clinic system. And I mean, I'm telling you, if you went there, you would go crazy. You know, like the first year I went there, I couldn't believe I was there. So I just want to really reiterate that like until we're dealing with that as a problem, we can never deal with any of these barriers. You know what I mean? And she's right. We need recovery housing, robust recovery housing. And I do like, there's a lot of good things with all these houses and a lot of bad things with all these houses. No one should ever, be able to kick you out, when you're using drugs and then you go die, and it's horrible. But like, We still need that flavor. There still needs to be all flavors of like this stuff. So if people don't like Oxford House, then don't go there. Do you know what I mean? I personally am not a fan, but I know people who do really great there. But it's part of the continuum. It's the whole point. I may not like entirely religious place, but I still want them to be there, and I still want people to have the choice. So until we're given those choices, these barriers are negligible to even talk about, because no one's fighting the main problem, and that's how they get us. So we're eradicate. So I just want to make sure that you understand that that's like, yeah. Sorry.
Staffing is just like it is everywhere, is a barrier as well. Not only recruiting and retaining staff, but finding the right people, because we're moving, as we move into different generations of the workforce, because of stigma, it creates barriers to staffing.
You do really well, though.
Thank you for that. Ashley, you got at this a little bit, but I'll go ahead and ask so y'all can respond to this one. How do you connect to someone who has a belief system that excludes Matt?
I think a lot of times when people are really against Matt, they've never had any kind of personal experience with it. There's a lot of ignorance. They're not educated about all of these different things. I heard one time a jail commander say he wasn't passing out naloxone because he didn't want people to get high. Like, naloxone does not make you high. And I think, that is a classic example of, somebody that is higher up that just doesn't have the knowledge that they need to be in that position making those types of decisions. And I also explain, I can honestly say that my beliefs about MAT have changed. When I came out of college, it looked very different than what it is now. And part of it was my lack of experience with it. And then when you start talking to people, I found out that my grandpa, who got sober from alcohol use disorder in the late 70s, early 80s, he used Antabuse. I would have loved for him to be alive still to have that conversation with him about what was that like. And he stayed on Antabuse for a really long time too, even way after he had gotten clean, because he was afraid, and not clean, sorry, had gotten sober. And he was scared that if he wasn't taking that medicine every single day, he would think that he could drink without it. And, seeing people that have taken medicated assisted treatment work and save their life, you can't hold on to those negative beliefs any longer. I think I see a lot of people, the more education they get, the more evolved their thinking about medicated assisted treatment is. And you have to talk to people that are taking it. If you don't know anyone that's taking it and you've not been around it and exposed to it, sure, you can have your opinion, but it's not a very educated opinion. You really need to know what's going on. And again, I tell people, you could kill them if you shame them with your negative beliefs about medicated assisted treatment. Come from a place of love.
And I think for myself, trying to present the information in a way that might connect with that individual. So for me, I kind of get to know them, where they're coming from. Did they have a personal experience, or is this just outdated information based on stigma? And, it's just, I get called names, I get judged very harshly for the type of work that I do, but I tell stories about individuals that we've served that have come out on the other side of things. I explain, like I did earlier, what a person goes through, the trauma that they suffer, and stories that I've been told by individuals in their most vulnerable moments. And that can be an eye-opener too, to say, could you imagine that this happened to you? Do you know that some individuals became addicted because their own parents or a family member gave them substances younger than 10 years old? Oh, no, that couldn't happen, but it does. And I think oftentimes people stick so hard to their beliefs because, again, if you peel back the curtain, it's upsetting. And some individuals just aren't willing to do that. And you have to know when to walk away, certainly to never be confrontational with someone. But if that message isn't getting across in the way that I'm presenting it, then I find a different avenue and try that. And then if they're still resistant, then I just try to lead by example to.
So I've done this a whole bunch of different ways, and I think that one of the things that about the best thing I can do is with allies, right? So a lot of times, like, I'm in a place where, you know, I have friends in city council, I have friends here, I have Ashley. If someone won't take it from me, they'll take it from someone else. You know what I mean? And I've noticed in this community that, like, there are a lot of people that I wish I would have known this 4 years ago, that if I leaned a little bit more on and brought them to different places, we'd be a lot further along. You know, at first I was angry, you know, and I think now, like, people like me and Ashley are talking a lot. The county's talking a lot. Everyone's talking a lot more. And I think the more that we intricately explore these things and talk about it, like, we have to get people to talk about their drug use. We have to get them to feel safe, you know. And I think that, like, that's the key to all of this, you know. I will say that, like, there's this thing that's came out of this endemic that's not so much just attested to this, but the idea of harm reduction, which has placed some things that have long been needed to happen, which is kind of giving drug users their human rights back and understanding that people who use drugs aren't bad because they use drugs and that they don't need to be off drugs necessarily. Although drugs have inherent harms, I'm not saying that. I'm just saying, like, it's people's choice, you know? We try to do it based on behavior, you know what I mean? And stop basing it on drugs. You know, there are no good or bad drugs. There's good or bad relationships with drugs, right? But that's really a hard thing for some people to swallow because we've all been raised. I mean, I was raised in the same world. Just say no. If Johnny uses drugs, he's horrible, you know? And it's hard for me to get my own internalized stigma out. You know what I mean? And we keep saying shame and stigma, and you'll hear all three of us say it all the time. It is a visceral thing. Like, I have spent most of my life where people die of an overdose. Whether I'd seen that person in 7 years, Nick, where'd they get the drugs? Nick, where'd they get the drugs? I don't know. I don't even talk to that guy in 7 years, you know? Because I did drugs once. So it has to be me. I have to know. Like, there's some drug club where all like, yeah, Jamie gave him the drug. You know what I mean? And then now we're actually trying to incarcerate people for someone who could have just shared a drug with somebody or for someone who sold it to them. Well, I hate to tell you this, 90% of drug users have to do something to get their drugs. They're poor. You know, there are situations where people harm other people. So let's not take that out of that. There are situations that arise where people have harmed people with drugs intentionally. That's horrible. You know what I mean? But I mean, like, we live in this world, and we live in a world where people are still getting locked up every day. People, you know, we punish every drug user there is as much as we can. Still to this day, we're doing good here. You know what I mean? We're taking these issues out and talking about them. You know, I see all of these faces in the room. I've seen it 1,000 different places working on this issue. You know what I mean? That is not the same in the world. I've spoke all over the country. It is not the same. You know, I often tell a lot of these people that, like, we have a special relationship here, you know, and the more I work with people in the field, and especially with her and Ashley and all us that work this job every day, that, like, A, it's psychically demanding. It is really hard. B, I will say that none of this can be done unless it's led by people impacted, and those people need to be put in decision-making positions. It's just not worked any other way. You know what I mean? If you have lived or living experience and then you get an education in this, that provides an expertise no one else can have unless you're in that position. That's what makes the sweet sauce. That's how we can reach people and get them back over the brink. You know what I mean? And I would just want to, like, stress very hard that, like, until we are openly able to do these things, we've got so many barriers, you know? I mean, hell, we can hardly talk about politics, you know? But talking about drug use will save lives. And that, like, when she says something like stigma or things kill like this, it's not just a buzzword. Do you know what I mean? I know many people who are dead right now. I know someone incredibly amazing and important who is dead right now because he didn't want the shame of dying of an overdose. He was so scared that people would think he overdosed that he did something dramatic, you know? And that's crazy. You know, like, went to the third ends of the world to make sure that he wasn't another statistic for people to ride on, So I just hope that's what I have to say about that.
Wow, I'm feeling that. Thank you. Well, you all are talking about amazing things, and you're kind of leading into my next question. I'm going to jump to this question because you've been talking about the misconceptions. Basically, you've named, and you didn't use the terminology implicit bias, but we have a lot of implicit bias about drug use in this culture. So the question is, what are some of the most common misconceptions about MAT, and how would you respond to those? Some of you've already addressed some of these, but if you want to say what hasn't been said or repeat some things that you want us to remember, that'd be great.
One of the things that I think is like a crazy phenomenon with medicated assisted treatment that we don't do with other medicine, and I don't know this for fact or anything, but if I was like, Lisa, I hear you're on Prozac. What is your dosage? What is your plan to get off of that? Nobody does that with anything else, but people, for whatever reason, like, oh, it's medicated assisted treatment, I should know that stuff. I'm like, are you a doctor? What does it matter to you how much they're taking or when they're going to stop? And putting like arbitrary timelines on you should not be on Suboxone for 7 years. Like, is he using heroin and fentanyl anymore? No. Well, why is this a problem? We all have things that happen to us, traumas that happen to us that change our brain chemistry. Because of traumas I've gone through, I have to take antidepressants, and I will my whole entire life because of things that I went through. It's the same sort of thing, and substance use is a symptom of something else going on, and a lot of times that is trauma, or they're self-medicating for mental health issues that are not otherwise being treated, or a pain condition that they have. And so really looking at there should not be any, and SAMHSA states that there should be no arbitrary timelines on that. And I know I kind of jumped into the next question, Lisa. You're supposed to take it for as long as it's a benefit. And a lot of the medications, they suggest you be on it for 1 to 2 years. And something we don't talk enough about in the recovery community, we talk a lot about acute withdrawal, but post-acute withdrawal syndrome, that can last up to 1 to 2 years for somebody's brain to go back to normal. And sometimes, depending on what happened, it may never go back to normal. I don't know what normal is. I don't think I've ever met a normal person. But it could take a while, and again, they might have to take it for the rest of their life, and there shouldn't be anything wrong with that. But for whatever reason, people think that it's their business to be talking about that and trying to put time limits on stuff.
One of my favorite quotes, which Dr. Gregory May, who was a close friend and colleague of mine, said one time at lunch, and I'll never forget it. He said, if we all knew each other's secrets, what a comfort that would be. And, also keeping in mind that every person is a different person, and that life is not a movie or a Netflix documentary. And if you're basing your opinions on someone who's suffering from addiction based off of those things, then it's not going to be accurate, because you need to connect with people on a human level to understand what they're going through. And I feel like that's something that I've kind of touched on many times throughout this conversation. But it is a recovery community. So if you have a family member that you have had a difficult relationship with because of their addiction, try to forgive that person. If I see that oftentimes someone will get their job back, get an apartment, get their children back. They're going to school plays and maybe volunteering at a local organization, and their family still looks at them the same way as when they did whenever they had a conflict in their relationship. And so it takes a village, it's a community. Everyone should have a seat at the table, and we should be able to speak respectfully to one another and hear what everyone has to say, because it needs to be solution based, because we are in the trenches and we need to be focused on saving people's lives. I agree with what Ashley has said as well. When it comes to the time frame, if we put a time limit on it and say, well, you need to be, weaned off of this medication by this time, it's not one size fits all. It's not cookie cutter. It's individualized, and it's based off of, someone might be, it's okay for someone to stumble and to fall back because of life circumstances, additional trauma, unexpected. I mean, look at what people are going through right now in Tennessee and in Florida. That could jeopardize someone's sobriety. So just keeping those things in mind.
Yeah, just so you guys know, if something like that happens, those guys aren't going to the clinic. Like, that's the first thing that shuts down. Like, we've been through this before. And they'll, maybe be able to go to the hospital once and get a dose, and that's it, depending on the state. So there was a big one in Georgia one year, and we were guest dosing it, and they just told us no, flat out no. Every hospital we went to, no. So we just went home. We couldn't stay the week. We couldn't go to Tybee Island. We couldn't do anything. Me and my wife just drove home. We're not going to sit down there for 8 days because there's no clinic we could get to dose us. No hospital will dose us. So that's the other thing. If you're sick and you miss your dose, because of the DEA rules, you very rarely are ever going to find anybody to help you. They put the I just let's stop from the negative, I guess. Could you repeat the question? I didn't hear it the first time. I watched that negative stuff.
Yeah, it's just uplifting misconceptions.
I think the whole idea is misconception. I don't think anybody understands the clinic system until they've been there, or the idea of MAT. She said something really poignant about the both of these did, but she said something about being on an antidepressant or something like that. There are meds that you can be on that the withdrawal from can kill you, and they have nothing to do with it. People just don't like that you feel. I mean, this is what I've come to believe. There's some idea that people can't stand about people feeling good, right? They don't like it. There's some kind of puritanical thing that, if this guy's feeling good, especially some 12-step abstinence-based recovery people, they think we're getting high. So they think it's like, damn it, I can't do this, and they can. They shouldn't be allowed to do this,
You address that, the misconception of getting high from MAT?
So MAT doesn't, when you first get on it, the whole point is to get on a drug that levels you out. If you're sometimes you get to a level too high and you get real naughty and so you're supposed to lower down. Do you know what I mean? You have to adjust your meds, and you have to think what you want out of this. I shouldn't say you have to lower down. For me, what I do is I get to a level that I'm okay with, and then I start backing down just a little bit, because I know methadone builds up over time. When I first started, because of not knowing anything, I shot up as high as I could, right? Which back then probably saved my life. It's just there's this funky misconception about what dose is and how it works and everything. It is a drug with a huge half-life, right? So it acts over time and stuff. More, I would say that the large part about all of this is just that, it's really no one's business what dose they're on. And if people see somebody on there, for me, okay, so I have hepatic encephalopathy, right? I had Hep C, and it messed up, so my brain doesn't produce, or it overproduces pneumonia. So a while back, I hadn't taken methadone for 3 days. I was wired. I felt sick. I hadn't been able to make it to the clinic. And this person I was just tired. And this person's like, oh, you must be on a good one, right? And I'm like, yeah, ammonia's shooting into my brain, which will kill me if I don't take this medication, right? So because I go to the clinic, they just assume that I was high. You know what I mean? And I think that people just have that assumption. It's not their fault. This is what society has bred into us. You have to know. We can't lay blame at this stuff. It's just what's been taught into us. But we can't break it now, The goal is to reach a level of medication that makes you feel okay each day. I have my own beliefs about what people should do on medication, how I want to do it. People should have theirs. I do also want to stress that if you're using, we can't tell people who are using to get off these drugs. These drugs will save their lives while they're using. It's really a misnomer. None of these people do that. I'm not saying that. But like, there's a big thing about like, we have to get off methadone someday. Why? Why? If I'm, like, if I'm not hurting you and I'm happy, I'm not driving car, if I'm not having that kind of, why do I need to get off it? Yeah, I don't tell you to get off your Xanax or Zoloft or any of that, or your heart medicine. And so when we get that, people say, oh, they must be getting high. That tends to be a problem because it doesn't work that way, especially with Suboxone. If you've been on it for a while, there's no feeling. You know what I mean? But what it does do is somewhere in your brain, it makes the switch flip enough that you're okay. So like I tell this tale, and I'll try not to take too much time. I tell this tale about when I first took a Vicodin. It was the first time I ever felt real. It was the first time I ever felt whole in my body as Nick Voiles, right? And I now know there's whole other stuff going on with me and this and that. But I felt real. I felt whole. So I began taking them for a while. Just little pieces, And that led to a whole bunch of other stuff. I got chaotic. I didn't have harm reduction. I didn't know how to deal with myself. But I can tell you now that, like, without opiates, without methadone, I am a much different person. A much different human being. For something in my brain, it makes me feel whole and positive. Usually people are like, why are you so tired? Or why aren't you tired? And I'm like, because it makes me want to work all day. Because really, I am a workaholic and it's horrible. But every idea people probably have is misconceived for a reason. They want it misconceived. Do you know what I mean? Like, I'm not trying to be conspiratorial, but like, it works for everyone's monetary advantage for the clinic system to be over in this place and for no one to look at it and talk about it, right? It's worked for years to gain a lot of money. Now with Medicaid expansion, it's just a money churner. They're just churning money out, And the whole idea about the high thing, which I try not to pay too much credence to because I think it's like at this point people know enough that it's really stupid to talk about that. There are people that abuse drugs. There's people that are going to take their dose up even though they feel it too high. They, like she said, have trauma. Maybe they have horrible pain. We don't know what's going on. And the system doesn't allow people to talk about that, right? So it is very rare that, like, you can go to a place and really feel trusty because they're coercing you. You're coerced to have treatment. You're coerced to have this. You're coerced to have that, right? None of these things are what you want or choose. But it's what you have to do in order to feel okay. Could you imagine that? If they did that with liquor, could you imagine? Oh, yeah, we had that. Riots in the street almost tore the government apart, right? So, I just think we need to look at this in a different way of that, like, we're learning so much now, that things are changing, I do want to make one misnomer. There are people who are always going to do something chaotic with drugs, right? The more we talk with those people and leave them a safe space to talk about it, it changes. That's what one thing harm reduction does is we talk about our drug use. And all of a sudden, these magical things happen. We're like, we can start really saying, well, I don't want to use as much, but I also don't want to be sick the next day. Well, have you tried less? You know what I mean? Same thing with with methadone. When I see people talking about methadone in their dose, I say, I think less is more. After years and years and years, I think sometimes less is more. So, like, I'll ride at a place and then I might go down or down. You know what I mean? I also have this big fear because when I did that one time, that thing happened with the bottle caps, and so I'm just gun shy now, But I just think that each person needs to be their own treatment and not other people telling them how they should have their treatment or their recovery.
I think a common misconception is that persons that utilize medication-assisted treatment like ours in a methadone clinic is that we're vaccinating cattle in a chute and they're just getting medication and we're sending them out the door. Our goal is to lay eyes on that individual, greet them when they come in the door. How did that job interview go? Let's get you in to see your counselor. This is, I've had conversations with patients where they've been in crisis and I've told them, you can tell me every bad thing you've ever done in your life and I'm still going to care, but I need to know how to help you. And I have very open, honest, cards on the table conversations in order to try to connect with individuals. But that is a common misconception, is that we're just there to just, that's the primary component. That's the whole reason why we're there. We're a treatment provider. We are there to try to treat the individual holistically. We also provide individual and group-based counseling. And my counseling supervisor can tell you something about almost every patient in our clinic, and it fascinates me because he can tell you their children's names and those are things that aren't considered when someone has a misconception about what we do.
I also want to add, I'm sorry, I have to add this. She is different. I've been to clinics all over. She is like making a change that you guys could not possibly understand. Like every other clinic I've ever been to is not like this. She has done things there that are game changing for someone like me. You know what I mean? She'll grab me and say, "Why do you look so tired, Nick? Just take off work. You can take off work." And I'll listen to
Mostly
her.
get a haircut.
Yeah, it's supposed to get a haircut. But like, I just want to add this, and I'm not trying to be like argument or everything, but like, she is something different, and what they've done there is something different. Do you know what I mean? Against all odds, they've done a different thing there. In my experience in every other clinic, and I've been to at least 20 or 30 of them, you know, that we shouldn't be mandated to have treatment. Treatment that's coercive does not work. Using a treatment indicator like using a treatment indicator like urinalysis should not work. We should ask for it as clients if we want it. If not, it doesn't matter. The truth is out there now. What she does is actually trying to be a real provider of a serious service. This also takes a lot of her time. It also comes with some combatants that are seriously stupid and just don't understand things. And I keep saying this to you guys, but I just really hope you understand that, like, she's different. These other clinic systems are broken and hurt people all the time. And the system itself is bad. She has just happened to make an oasis where by her will, she is making other things happen and hiring good people that do the same thing she does. I just don't want you to get tricked into thinking that this clinic system is okay. She's just crazy cool and good at what she does.
Thank you, Nick. For me personally, I hear that, but I don't hear that at the same time because we've got such a long way to go. It is about continuity of care. And there's also a common misconception that it's like you see in the movies. And, you know, what we try to do is to show patients what they deserve. You deserve to be treated the same by each person you encounter throughout our building, whether it be a counselor, a nurse, a physician, that your patient experience matters, that your clinic environment should be warm and welcoming, and there shouldn't be, 20 posters on the wall with messages that don't really hold weight, inspirational quotes and words of encouragement, honoring individuals that have passed away from overdose, feeling safe. I'll see you tomorrow, and having that connection. And I've seen patients want to make the staff proud, and they show off. I got the job. I had a visit with my children. I got to go see my mom today and go to Thanksgiving dinner. And so there's just so many common misconceptions, and that's why I open my doors and I invite every person in this room, and I would be happy for anyone online to reach out to me and say, I'd like to come and meet your staff and learn more and get a tour of your building. Because, like I said, everyone needs to have a seat at the table if we're going to combat this problem.
Well, the research shows that safe, stable, nurturing environments have a dramatic impact on well-being, and any trauma-informed organization is going to be a safe and stable, nurturing environment. So it sounds like you've really, well, I know all three of you work really hard at that. So thank you. So I'm going to ask one more question, and then we'll just see if anybody has questions that's on Teams or in the audience. If you're on Teams, you can raise your hand and somebody will unmute you. And then, of course, in the audience here, y'all can come up here and ask your question. And then if we have time, then I'll let y'all have last words. But also, if we have time, I'll ask another question. This question, let's see. Yes. So you've touched on this a little bit, but how do you empower someone who is considering MAT? You know, somebody who may be hearing different messages and they're not sure. So how would you, not to convince them, we're not looking for that, but how would you empower them to make the choice that's best for them with regards to MAT?
I always start by educating them. They can't make a decision if they don't know what all of their options are. And then, really explaining to them, because I think a lot of people struggle with the fact that if I have to take medication, that's a weakness. They see that as though like there's something wrong with me and I need to take medicine. And explaining that's not a weakness. In fact, like, it's pretty brave to put yourself out there and ask for the help that you need, even when that includes medication. And, also that this is their recovery. And it can look a lot of different ways, because I think a lot of people will come to me and they're like, what do I do? I'm like, I am not you. I can't tell you what to do. Like, you have to make these choices, but let's look at all the different options. And then sometimes when, they've tried a medicated assisted treatment, it didn't work, like kind of reviewing what was going around that, like in terms of like their return to use or that sort of thing, because, one medicine may not work and another one is, the silver bullet for them that makes them feel normal. And so really looking at that and knowing that their recovery can look any way that it needs to meet their needs, and meeting them where they're at, instead of, talking to them from like up on a pedestal, like I know better. They are the expert of their own life, and you have to listen to them and what they want, what they need, and, help them get to those things.
Being genuine and just present for them to tell their story, to answer any questions that they might have. A lot of times I hear stories of, well, my wife doesn't know that I am experiencing addiction, or my family. And so just walking them through everything that they'll experience when they come in, asking them, do you have a ride to get here? Can we help you set that up? It's all those little minute details, because when you pick up the phone and you have someone on the other end of the line that is asking you for help, every second that ticks by is vital to their survival, because they're making a choice. And that's another common misconception about the treatment that's provided, is that somehow there's some negative context or something sinister that individual is trying to gain by being in that program. They're making a choice. We talked about all the things that they do to try to just get to you so they can feel stable and work towards their goals, and asking them, what are some goals that you have? Because oftentimes when I'm interacting with people, they have lost sight of their dreams. We have an art contest every year, and you would be amazed at how beautiful the things are that people create, and by hand too. Like, they should be in a gallery downtown. But like Ashley said, just empowering that person that they should hold their head high. And I'm proud of you for making this phone call. But education is key, and just walking through, let's just get through until the morning, and I'll see you in the morning. And my name's Autumn, and you'll meet Adrienne. She'll help you with your paperwork, and just walking them through so they know that someone is standing there with a smile on their face, excited for them to take that next step. So I think that's a big part of it, is education, support, and just empowering them that they are making the right choice.
I think the biggest thing we can do as people with lived or living experience to be there. There is nothing that can replace looking into someone's eyes and knowing that they've been there before. So, like, at every juncture, we need people who have lived or living experience to be part of that. I mean, that's what's changed. That's that's what's been the shift in America right now. That's even causing any sort of like change. Is that we decided to change over to harm reduction to some of its tenets, you know, and the idea of putting people with lived experience in places means they trust them, and it's like an intrinsic trust, you know. So if someone comes to a place and they see me and Scotty are sitting outside and we're okay, things aren't bad, nothing bad's going on, and they ask us questions, and we're like, no, just go talk to like. I don't think you understand that no one talks to the director at clinics. That doesn't happen, right? It just never happens. I've talked to 2 directors in my God too many years. So like having access to people like that is huge because they're gonna believe it. You know what I mean? They're gonna believe what happens. Giving people robust information about the laws. Everybody should know what are the laws, what the clinic is doing, and what the staff are doing. 90% of the time, the staff can do nothing about these laws. There's times the DEA requires you to be closed or you're fined $10,000. There's, you know what I mean? There's all these things that go into bind the hands of people at clinics that you just, if you don't know, you don't know. Once you unpeel all these layers, you realize that more of the fault is on the laws and people not fighting against it, you know? People with lived experience can make these connections in seconds that take people years to make, you know? We recently had a woman missing, and everyone's looking for her, the police, everyone. We found them because people trust us. You know what I mean? And it's that kind of thing, especially in drug use and in getting into some sort of recovery. They trust that. You know what I mean? You can tell. We know our people. You know, some of the best things I've ever seen are in AA meetings. Back in the day when I used to go, this intrinsic like moving of an anonymous trust. You know, it used to be an impenetrable wall. They would rather die than give up the people in AA because they knew that if they did, it meant them losing their job. It meant them losing their life, their marriage, whatever. And that kind of thing is carried on into harm reduction in the sense that, like, we care for our own, you know? And I think that's such a huge piece that we look past too much, you know?
Something else that came to mind that we haven't yet talked about is when it comes to lived experience. A lot of our treatment providers in this field have lived experience and have come to a place in their recovery where they're now able to help other individuals, whether that be by being a counselor or a recovery coach. So that gives people a lot of hope as well, and someone that they can connect with that can relate to what they're going through.
That's huge. I think that's the biggest piece we have right now. I think there's nothing more important than that on the face of anything that's going on.
I have to say, and I've been in the field a while, there's 2 people that work at Centerstone that used to be my clients. And it warms my heart so much to see them in their life, living their life to the fullest, helping other people now, taking their bad experiences and using that to help somebody else through their struggle. There's nothing more powerful than that. And it warms my heart, and I love to see that. And that's how it should happen, you know, is people that they get better, a lot of them come back and they want to be in the helping profession to you know, give back and to let their experience kind of guide other people to hope.
Yeah, that's beautiful. Thank you. Let's see. Anyone have any questions? Yeah, come on up. Get up here. And then put your hand up. I don't really know how Teams works. I'm not very good at Teams, but I think you put your hand up or something. But there is somebody up there that will unmute you if you have a question on Teams.
Hi, my name is Bruce Terry. I am in recovery, and I have done sober living houses. I've done it all. My question is a health question. You talk about people can be on these for long term. Who's monitoring the rest of their body, their liver and everything else? Who takes care of that? I mean, because I know that long-term use of methadone can cause liver damage. So there are some of these drugs, I mean, they may have changed over the years, okay? They may have changed over the years. I don't know. I didn't do methadone. I didn't, there are a lot of things that I didn't do, but I found recovery anyway. But I'm just more concerned about health issues with liver or whatever else can go wrong. That's my question on long-term usage.
And what I would say to that is a legitimate treatment provider, especially the physician, should be very transparent about whether it be in our setting or in the primary care setting or in the inpatient environment, be willing to take the time to share those side effects and what your pre-existing conditions are. So I can speak for the treatment that we provide is we do initial blood work that we send off to a lab. We also do annual blood work. We do EKGs in office to monitor patients that may have underlying heart conditions. And we also try to do referrals to, it's huge when we can connect with Centerstone and try to link services, because Centerstone does many wraparound services. And so I think that when looking for a medication-assisted treatment program, you need to do your research. If you sit down with a physician and they just say, okay, we're gonna prescribe you methadone today, like I said, vaccinating cattle in a chute, that's not the right program for you, because I can speak for the providers that we have. They spend extensive amount of time with the patient, answer any questions, plus open office hours. Any of our patients at any point can say, can you get me in to see the doctor because I have questions, or they've been recently diagnosed. That's what it should look like. But in speaking to that, sometimes that's how individuals get addicted to prescription medications, is because they haven't been given that education. So
you're absolutely right on that. That was just a question I had, because when we're talking about long term, I have to think that because I was on painkillers for years, and so I know what it's like to have to come off of those, and I think it was starting to affect my liver. And so that was one of the main reasons I got off on it. And of course, it's just one of those. That was just the question I had.
I'd like to answer that myself, just to help you out a little bit. So a lot of times what we're finding out, especially in those old painkillers, had a lot of Tylenol in them. So what you actually had was probably Tylenol toxicity, not necessarily that. So even something like a Percocet has 325 milligrams or 500 milligrams of Tylenol in it. If you're taking Vicodin, it used to have 1,000 milligrams and 10 milligrams of Tylenol. That's why Tylenol is getting taken off the street, having a big problem right now. Liver toxicity comes from Tylenol. We thought that it was doing that with the liver. You're right. I'm old like you. I remember that. Okay. That was also, we didn't have HCV stuff, and we didn't understand what was going on with the liver a lot of times. What I will say is this. There's common misconceptions we don't know enough about, but methadone has been around for longer than any other drug and has the least amount of side effects. Right now, we don't know with Suboxone. We're seeing tooth decay of Sublocade, or the stuff that's put in your mouth. We're seeing other things. When I started the clinic, they said it gets in your bones and rots your teeth. I'm sorry to say, but opioid users like sweets. And I can tell you firsthand that, it just happens like that. I don't know what that is, but when I started the clinic, I had chocolate milk and donuts. And then one time, I finally had to look at myself what the hell am I? I have 30 pounds of donuts on me now. I will say that, I keep saying this, not her and her clinic. The clinics are set up not to help you in any way. You should be having, in that sense, right? You should have a physician. When we talk about a physician, a true physician, not a quack, you go into your doctor. I don't know if you know your doctor, but I've had good doctors and quack doctors and croakers and all that. A good doctor will walk through everything with you. He'll have you come and talk about how are you feeling. Well, you have 8 pills a day now. Is that enough? Do you need less? And if they're taking 8 pills a day and they're coming to the office like, oh, it's great, doc. Yeah, I'm loving it. The doctor's going to know. You build these relationships with doctors over time is what it's supposed to happen. America is so concentrated on dollars that a lot of times you might get 8 to 15 minutes with a doctor a month. It's a tragedy. The clinic system is a system of cruelty that does not care for physicians to give a shit about what's going on. If you look at the rates of HCV and other stuff that's going through there, It's unreal because they don't provide it every 3 months. By Medicaid, they only do it every once or twice a year. She's 10 times better than the rest of them. She has us there testing all the time. She has, you know what I mean? But you have to look at it like that. Until we break apart these systems and get doctors that care, that aren't just incentivized by money, you're right. There is no healthcare there. There's referrals if people are okay enough to do them. If they don't have the stigma built up that they get treated like shit at hospitals, 90% of people who use drugs have horrible. We have the statistics now that like won't even go into hospitals because they're treated so bad. So that all of these things are weighing in. That's one of the reasons we're pushing to release methadone, at least have a choice to go to a doctor. I'd rather go to my doctor who's known me for 10 years and knows every movement I make, knows I have this thing going on and that thing going on, to be like, listen, you've been on this dose for a while. Can you go down? You're going to have much better stuff with your liver. Maybe you'll have a better bowel or whatever. And if you don't, this is what's going to happen to you. And he's going to sit with me there for an hour, or he's going to call me and be like, did you, what's going on? You know, that's a good doctor. I don't mean horrible doctors. You know what I mean? And until we have that kind of like connection, then we're failing our patients completely, and health conditions will continue to rise in crazy spaces. And yeah, there is things that we don't know. We don't have data right now that shows us, yes, this doesn't happen, yes, this does happen. So no, we need robust care. We need to change the clinic systems as they are and make an option for people to go to a physician of their choice, where they can receive the medication as they choose from a pharmacy and not be stigmatized by walking into a clinic every day.
Thank you.
You're welcome. Great question.
Right. Looks like we're about out of time. So I'm going to bring you into some time for just a few things that maybe you haven't had a chance to say. We did have a question about like what you would want to improve or changes, which a lot of you did get to. But if there's something that hasn't been said yet that you would want the system to improve with regards to MAT, or changes you'd like to see, you can name that, or just anything else that maybe you've already said but you want to have as your parting words.
I think we did have one last question in the back.
Great. Do you want to come up? Do you all mind going over a little bit? Okay.
Autumn, thank you. You're amazing. Thank you for giving me a little hope in the methadone system. You created a stigma-free place for me to come, and I think it's amazing. Nicholas, so we were talking about misconceptions earlier, and I want to go back to the take-home thing. So the news outlets, and please make people believe that there's methadone diversion, that people sell their methadone when they get take-homes. It doesn't happen. I'm here to tell you, as a person who's been in and out of methadone clinics for 24 years, people do not sell their methadone. People who are on methadone need it. They have to have it. They don't want to sell it, and it just doesn't. It's such a fallacy that it breaks down the system, and it makes people think that, and that's why we can't get those 30 take-homes like other states can, because Indiana doesn't trust us. So I thought what you have to say about that.
We have, like I mentioned earlier, earned take-homes. The patients have invested a lot into being able to take the medication out for self-administration. So that medication can be very precious to those individuals. There are guidelines in place to monitor for those types of things, and what happens is, we are held to a standard, and we have to meet that standard of being good stewards and following the guidelines and following up with patients and engaging with them in such a way that I've actually had patients come to me and say, I've relapsed and I don't trust myself. Here's my take-homes. And
they're safe environments, people can do that.
And handing back full bottles of medication, and then and this has happened, this is, not some, fanciful story of someone saying, and now I need to go to treatment. So I don't want to speak on behalf of large numbers of people or about the system as a whole, but only for what happens under our roof. But the state does put guidelines in place to and responsibilities upon us to make sure we're engaging and monitoring where that medication is going. And we do medication callbacks to come in, have the patients come in and count their medication in front of the nurse. And that's very successful as well. So it's a misconception, again, that the patient is doing something devious and with malice. And it may be that that person has had a significant change in circumstances and they've relapsed and something's changed. And
we don't extend goodwill like we would to just your average citizen. That people who use drugs don't get that goodwill, do they? No.
Not as much as they should.
And I can say that as far as in the state of Indiana, there are many other treatment providers just like myself that I meet with quarterly. We all get together. The state facilitates that are fighting the good fight, who are trying to overcome stigma, that are facing a lot of the same barriers and challenges that we've faced, that have wonderful staff. Like I said, I hear the praise, but I don't hear the praise. We've all got a tremendous amount of work ahead.
I just want to always relate to you guys that, like, she's amazing what she's done, like, and that place is different. Like, this is not what happens, right? Like, who gets to tell you to take what medication? If I walked in, I mean, it's just the idea of, like, that you're flawed because you're a drug user or you're going to do something devious. If you knew some of the drug users I knew, you'd go running. Some of them are in local policemen, cop, but I'm just using that. I don't really know a cop, but I'm just saying, like, it affects everybody, right? And the idea that you come in flawed so that you can't be trusted because you're somebody who uses drugs is so inherently wrong. So how else are you going to feel good? You're flawed from the second you walk in the door. No, you can't take your medication home. You'll abuse it. You'll do something with it. Well, no, I won't. Not if you tell me not to. Yes, you will. If I told you that with your Prozac, like, seriously, like, I mean, I hope you guys, it sinks in a little bit. Like, you come under the guise of you're wrong to these clinic systems. Also, no, most all of addiction stuff, we haven't changed that much. We're trying to. Coercive treatment does not work. It doesn't work. You can't tell someone they have to do this to get their medication or to tell somebody they have to do this to be okay. Pretty soon that stuff will hopefully be illegal and you won't be able to coerce people to do things like that. I'll tell you, the hardest thing I ever had to do was overcome the idea that I wasn't a piece of shit. It took me years to dig into that. And I use that term, I'm sorry to cuss, but, like, there's where I learned it. You want to know where I learned it? The clinics. I learned it at treatment facilities. They told me I wasn't worth anything when I walked in the door. They don't tell me that shit no more.
Any other parting thoughts before we move to
That's it.
Ashley?
I
Okay,
wanted
thank
to-
you, Nick.
To just say real quick too, because I don't think people that are not familiar with opioid treatment programs don't realize that methadone is liquid. It is liquid in the state of Indiana. Methadone pills that are getting out there, that they are not coming from OTPs. And I think that is a common misconception that, you hear of people overdosing from methadone pills and just assume that it's coming from an OTP, and it's not. That is only liquid in the state of Indiana.
And the medication that we dispense in the day of the life of a patient, if they come in and they don't have appointments with us, and they're just, that day is their day to just come in, they don't have any other services that they need, they log into our kiosk that alerts the nurse. They go up to a medication window. The nurse verifies all the information that they need to ensure that that's the correct patient. And a licensed nurse observes that patient. They cannot leave that area. They can't even take a step back. They can't have other items like a purse or a cell phone. So I think people don't quite understand that component either. But, oftentimes just a parting thought is you pass by individuals that are or what they call panhandling, or they have a sign that says, "We'll work for food." And I often, oh, they're just going to use it for drugs or alcohol. Have you ever gotten out of your car and handed someone a sandwich and a bottle of water and asked them what their story was and what type of help that they needed? Because I have. And I've given them my business card and I've invited them to come. Even if we can't help you with the services we provide, at least come and talk to someone and maybe we can connect you with other services. But that's the difference. It's like, oh, well, if I just give them, $5, they're probably going to go and use it for something else. But have you ever gotten out and taken that time to connect with that individual? Because it's life-changing and it will completely change your perspective. And it's a blessing to look at someone through my eyes and see a young girl that looks to me like a Disney princess and someone else looks at them and judges because of the way that their physical appearance is, because I've gotten to know the heart and soul of that individual. So that's the message that I carry with me in representation of what we do and how we do it and trying to eliminate stigma.
You want to say one thing about this supposed methadone overdoses? We used to believe that because of some bad death data that's been debunked now. In like the 90s and then again in the 2000s, we had this idea that we thought methadone coming from doctors was killing people. It's absolute farce. We just disproved it 3 or 4 different times by the doctors who actually did the autopsies. What they said is anyone who's in here who's dead and has methadone in their system, tell us. And that's what they counted as overdoses. So if you died from a heart attack and you had methadone, you look it up. Please look in those Google Scholar, look it up. It's been debunked several times now. But we still ride on that data. I think things are really different when you look at them that way. I think exactly what she said about people who are panhandling, like, even if you just give them $5 and say, I'll give you $5 to tell me your story, right? It doesn't matter what you give them, but you would be so surprised. I know I've said it a bunch, but it's a different thing to be treated like a human in a place that's treated you horribly. And it's funny that I have to even think that way. So scary that I have to be glad that I'm being treated well. But in a place that you can get treated really bad, to have someone give you that is something that is magical. And she can say all what she wants to say, but to coming from a place where I've had people just flat out, just, the worst thing you could ever think of, on the other side is nice, even if it's just a small thing, even if it's just asking the guy to take his boot a little bit off my neck, it still means something,
And to close, I just wanted to remind people that the opposite of addiction is not sobriety. It's being connected with other people. Addiction disconnects people from having a place to live, having friends. We need to connect them, and finding that recovery community, whatever type of recovery community that is, wherever they are in the recovery journey, is huge, because we're just all humans. Nobody would want to be judged by a list of all of your worst decisions, but that is what people do regularly to people that are in active addiction, and even people in recovery, even if they've been doing well for a long time. And so just dig deep in your hearts and find that love and compassion for a person that has different struggles than you, because loving them will help heal them.
Well, on behalf of the CARES Board, Nick and Autumn and Ashley, thank you so much for giving not only your expertise and your time, but your love and compassion. We can all feel it. I can feel it for sure. And I know I feel pretty confident that it's contagious in a good way. If anyone is listening or watching and wants to know more about the CARES Board or might want to serve on the CARES Board, you can email me at llm as in Mary, EUS as in Sam, ER @me.com. And with that, I think we will call it a night. All right. Thanks a lot for coming and watching.
Thank you.
Thanks.